What I am often moved by is the capacity for change among people with cancer and their loved ones as they confront existential threats, mortality. Hope isn't about something 10 years from now. It might be hope for something tomorrow. It might be next week. Patients who have advanced cancer often, like within the first 15 minutes, even if the therapist doesn't ask, they're talking about death and dying. So we know they want to talk about that.
So, hello everyone. Nice to see you again to a new edition of Beyond the Cancer Diagnosis interview series. Today is my pleasure to present you my guest, Janet de Groot. She's professor at University of Calgary. She's a psychiatrist, oncologist, and community health sciences. But she has interest in strategic fields related to oncology and psychoncology. Janet, welcome. Thank you for accepting our invitation. We are very glad that you accepted. And to begin our interview, I would like to ask you to uh, elaborate on what these areas that are connected with oncology, especially with psychoncologies, are, and what is your motivation
Okay.
that make you over the time dealing with cancer patients?
Thank you very much, Adrian. I think that's a really great question just to start. And I've been thinking about these ideas. But so say I'll just say a first generation female psychiatrist, and I work as a clinician researcher in psychosocial oncology. And my interest is essentially being contributing to worldwide efforts to meet the psychosocial needs of diverse people with different cultures who are diagnosed and treated with cancer. And my special focus would be on advanced cancer, mostly of solid tumor cancers. And I'll just say there are three main research areas that I work in, and my aim is now to integrate them further. But I've been doing some implementation research. So for calm counseling for people with advanced cancer, and I'll talk about that more later, right? And also the digital storytelling. And our team is exploring whether digital storytelling in a group format is therapeutic. And then finally, medical education to support allyship with Indigenous people of Canada right now who are diagnosed and treated for cancer. But so, in my day-to-day clinical work, what I am often moved by is the capacity for change among people with cancer and their loved ones as they confront existential threats, mortality, which is introduced by the disease. And I can see changes like people have more self-advocacy or more valuing of relationships, more communication in relationships. They might develop new relationships or let go of some. There's post-traumatic growth, which I know you're interested in, and also acceptance of mortality, which is particularly important with those who have the advanced cancer. I also feel quite honored to be engaged in the therapeutic relationships, like to talk with people, co-construct meaning for the person's self and self-understanding and understanding of others, whether it's healthcare providers, their loved ones, friends, but in ways that help them navigate cancer and life after cancer, if that's where they are too.
You mentioned three main direction
Yeah.
of your currently work. Two are, let's say, therapeutic. One it's related to the field of educations, and as you all know, that education is the basis of knowledge. And you mentioned about acceptance. We can't accept if we don't know. So, and if we can't accept ourselves, we can't change.
Yeah.
So all these issues that you mentioned are hand in hand. But I would like to talk more about the therapeutic work of you. And I will start with a pilot project that you've developed to evaluate the therapeutic potential named Digitally Storytelling Group for premenopausal women with breast cancer. Could you let us know what, or give us more details? What is this project about?
Yeah. So again, this is a project I'm sort of excited, or I am excited about, but it came about from working with a colleague who is a professor of social work, and she does a lot of multisensory research. And when we did our Calm study, which we asked people also, we asked caregivers to do whether they were interested in digital stories to talk more about their experience in navigating cancer with their loved one. And ultimately, we didn't get many people interested, but we found that the people who had advanced cancer were interested in digital stories. And and what we found is like they wanted to talk about living with the illness and some of talking about calm. Often they were quite ill and only months or weeks from death, so they had a lot of support in making their stories. But they also talked about the story making being therapeutic. And there's been some writing in the literature about that too. So we thought, well, what if we set out to examine this? And then we have a multidisciplinary team, and there's psychologists who work a lot with women with breast cancer, and said that those uh, who are premenopausal with breast cancer, they're not always addressed, and maybe their stories are going to be important too, for knowledge translation as well. And so we invited this group of women to partake in a group, and the group would be 5 to 6 sessions. We wanted to have at least 6 women. We had 7, and they initially just talked about their experience of cancer, but also the facilitators had 2 had a background in social work, and they also knew how to make digital stories. So they supported women in telling their story of living with cancer or experiences in relation to healthcare providers. And they made 3 to 5 minute videos. But then we also had asked pre and post questionnaires like around depression, fear of recurrence, and so pre and post. And we're seeing like it's a small group, but there are trends for change toward improvement. We also invited them to interviews, and they're talking about ways that telling this story, like it was difficult, emotions arose that they maybe didn't even expect at times. But by the time they've completed the story, they felt empowered and they had something they can share if they want to. And many felt that those painful emotions were not so prevalent anymore. So I think there's a hint that this is therapeutic, and, and there's certainly group components, but some of it may be by actually actively telling a short story with their own, with their photos, with music, with their own voice. And these are quite powerful, and we can use them in education as well. And we're hoping to do or we're planning to do a larger study.
That will be very important, and we've discussed before. We started the interview about the cultural background. For example, in Romania, I have patients, yes, that had breast cancer, and she did radiotherapy. And because she wanted so much to have a baby, she wanted to the issue of fertilization, fertility in vitro, and that caused this menopause as a side effect.
Yeah.
And the idea is that in her case, this cancer diagnosis is like in the shadow, because now she's, let's say, not desperate, but she didn't know what to do, because she has two diagnoses, and which is the important one, she put it in the shadow. And I guess, and I believe that this, let's say, this project will be very helpful to understand, because we talk about education, so we talk about acceptance, to understand that each, let's say, decisions has consequences, and it's very important to be informed and to take care of you. So I guess it's very important for the future, because as we know, it is this paradox of breast cancer at women. Uh, we always said that breast cancer is one of the cancer types that are, let's say, treatable, but on the same time, the majority of women are dying because of breast cancer. So each instrument, each project, each pilot study, it is a help in this process of awareness. And now I want to go further and to come to your soul project, which is Calm, and you mentioned several times. And I know that you work a lot on developing this therapeutic process. And I will start by asking you these initials, Calm, CALM, or where are they come from?
Okay. Yeah, so calm, as you say, CLAM, I will say it was developed by my colleagues at Princess Margaret in Toronto, and there's Dr. Gary Roden and Sarah Hales, and they developed the name Managing Cancer and Living Meaningfully. So the M is silent, but so cancer and living meaningfully is the calm. And but I think it's also, so it's a useful name, and it's sort of people like the name. It's like, oh, this,
For,
you know,
for
Right.
example,
Yeah.
for for example, in Romania, calm means quiet.
Yes. Here.
So yeah, it's yeah, it's a good choice.
Yeah.
And what is the story behind the project, or the starting point of this
Yeah.
therapeutic process?
No, it's important. And I would say the research project we did very much was based on talking with with clinicians and our clinical leaders here in psychosocial oncology. Because, well, we are fortunate here in Calgary. We have a large psychosocial program with many psychologists, social work, a few psychiatrists. We have spiritual care. There's also a rehab. So we have many resources, and it's right within a cancer hospital. We're also linked, like we have a southern Alberta, so it's a big province, but in the province, there's an area that also includes a setting to the south at 200 kilometers away. So we had two sites involved. One was psychosocial and one was palliative. But the question was, we've got all kinds of resources. People get supportive expressive treatment, or they can do mindfulness, they can do groups. And we had it more tumor based, so that the clinicians were more focused on breast cancer or GI cancer. But so the question was, this is for advanced cancer, solid tumors. How are we going to refer? How do we know who needs it? And so ultimately, it became what we call implementation research. How do you integrate evidence-based treatment, which Calm was already? There had been 2 RCTs and other pilot studies. And so how do you bring Calm to a new setting? And in doing that, we had to find referral routes, find out how the organization either facilitates or has barriers. What about clinicians? So the oncologists, the nurses, how do we get referrals also from palliative care or psychosocial oncology? So our focus was, how do you integrate. And we also needed to, a secondary part was efficacy. Like, we know there is efficacy, but we wanted to know when, like, it's not systematized how people come to us. It would have been knowledge of the study. And we had to do a lot of educational sessions, like 15, 20-minute ones. And I did it with a master's student, and we'd meet with like the gynae oncology group, who have many people with advanced cancer, lung cancer, palliative care, many groups. And so we would give out scripts, like, how do you talk to your patient about, we're treating you for advanced cancer, and this is an intervention for people with treatable but non-curable cancer. We gave postcards. So there was education, there was research. We asked clinicians what would promote referral and what would halt referral. And so, but implementation research, I could also say, it's newer in psychosocial oncology. Like, I guess at one time, there's a 2019 paper saying that often for something that's evidence-based, it takes 17 years to have 14% of studies integrated into care. So we know it doesn't happen easily, and you need to study how it happens. And so ultimately, what we found is that patients who at least had 10 months life expectancy or more, who are referred directly by their oncology clinicians, that could be a nurse, that could be the oncologist, it could be palliative care, psychosocial, but those were the people that were most likely, their patients were most likely to say, yes, I'd like to do calm. And at the end of that, what we felt was that we have to increase equitable access to evidence-based calm for people with advanced cancer, and ideally within 8 weeks of diagnosis. And our values for that are like meaning, equity, and dignity. Yeah, so this project was kind of large, comprehensive, based on implementation science, but took lots of education, and then at the same time, we were training people to provide calm. I had been trained by my colleagues, and now we did sort of co-supervision of the training of people here in Calgary and Lethbridge, a community to the south.
You said about advanced cancer.
Yes.
Yes. And this calm could be applied, for example, to patients post-diagnosis, not immediately after, but as you mentioned, 4 weeks, 5 weeks with cancer not so advanced, curable, but let's say easy cases of
Well,
cancer.
actually, it's only for it was developed originally for people who have treatable but non-curable. So they're typically stage 4 or stage 3 recurrent. But our ideal is that after that diagnosis of stage 3 recurrent, stage 4 solid tumor cancers, that they get referred, because they're often the most distressed, most depressed in the first 8 weeks. But it could be that some, like, at least that our ideal is that they would be advised about it and referred, but not everyone will come, and that they might, if they're not interested then, but that they could be referred at a later point, maybe when there's progression. So but having that awareness throughout the treatment of advanced cancer.
I have now to ask you this before we move forward. So for our audience to understand, calm, it's a therapeutic process, yes, for patients with stage 3, 4 of cancer, more or less, let's say, like pre-palliative care.
Yes.
No?
Or early palliative care.
Yes. Okay, just to be sure that everybody will understand correctly. So it's the step before enter on the palliative, because you mentioned dignity, and yes, we all know about the dignity
Yeah.
therapy, which is the next step
Yeah.
after
Yeah. Yeah.
calm. Uh, f- could you share with us the calm counseling in terms of sessions, how it's organized in time,
Yeah.
like time of each sessions, the interval between the sessions, how is it
Yeah.
work?
Yeah. So typically, it's 3 to 6 sessions, and people are advised from the beginning so that they anticipate its limited time and that it's in for the individual, so it's one-on-one with a therapist, but they're also invited to include a close other, so that could be a spouse or an adult child or even a friend and who's quite involved in their care in one or more sessions. So some people have that their spouse in every session, some might have that in one session or an adult child. Those sessions are like 45 to 60 minutes, so nearly an hour. And what we talk about, like the first session would be definitely an hour, and the person would be invited to talk about their experience of cancer so far. And that often lets us know about their emotional experience, their relationships, their expectations of healthcare providers. And in that session, we also ask about 4 domains that are typical concerns for people with the advanced cancer. So the first is symptom management and communication. So it's very cancer related. Like, are they having pain? Is it being managed? Can they talk with their healthcare provider? Um, and for, those are that's the first. And then the second is how has the person changed since their diagnosis of the advanced cancer and how have relationships changed? And sometimes this might be that the person is feeling less independent because of relying on others. Um, the third is meaning, purpose, and spirituality. So, what gives this person meaning in their life now and in the past? Like, is legacy important to them? And how do they understand cancer? They're having cancer in the context of their beliefs. And then the final domain is about the future, hope, and mortality. And their questions might be, how are you thinking about the future? What provides hope for you? And so for some people, it's also shifting that hope isn't about something 10 years from now. It might be hope for something tomorrow. It might be next week. It might be, the graduation of a child or a grandchild, um, a wedding. There's different forms of hope. And then what are the person's concerns about death and dying and even practical issues like have they made a will and have they talked about the, end of life concerns with family? Yeah. So 3 to 6 sessions, that's the topics, and usually we figure out, like, which domains are most important to the person. The second session is often within 2 to 3 weeks, so we really build the therapeutic alliance, and then it might be once a month. But for some people, it gets spread even more, like, they start feeling like they're doing okay, and for some they may have some extra sessions as they're dealing with depression, for instance, or distress. But to have the short-term therapy, there's a certain belief that through the process, the person will become more resilient, more be able to navigate advanced cancer, or they as a couple may be more able to communicate and address future concerns.
This is an innovative, let's say, therapeutic process, and because it's not like the usually cliche, to put it like this, when we as specialists, yes,
Yeah.
we We, in the first sessions, will tell each patient what the future of the therapy will look like, yes, what
We-
he or she should expect, and so on. This is the reverse. You ask them directly, what
Yeah.
do you think? What is your meaning? What is your legacy? So it's you enter direct in the subject of what is happening right now, yeah, what you will have behind,
Yeah.
how you see the future as
And
much as it is.
yes. And a lot of the research by, my colleagues, and they've done it with students and people in other countries too, and they've found like patients who have advanced cancer often like within the first 15 minutes, even if the therapist doesn't ask, they're talking about death and dying. So we know they want to talk about that. And all these concerns were like these four domains were developed by asking people with lived experience of advanced cancer, like about their concerns. And so it wasn't therapist just derived, it was derived from people who have lived experience of advanced cancer. And so I think it resonates with the person. Like it's, okay, this has been on my mind anyway. Now this person will talk with me about it. It depends on culture too, how much the person wanted to know about prognosis but it requires being referred with the knowledge they have advanced cancer.
Now I again have to ask you something. You mentioned about talking each patient about death and dying, which is quite interesting, in the first 15 minutes, because, uh, for example, in Eastern Europe, this is the only thing or the last thing that we are talking about
Mhm.
in cancer treatment, and it's at, at the very end, this topic. And when you mentioned that they are talking about death and dying, you or your colleagues, the researchers, how they felt the patients when talking about death and dying. They felt like being scared, or how they were. How did they were when talking about this issue?
Well, no, that's a good question. Like, so just stepping back. So when people talk about it in the first 15 minutes, it's because the patient starts talking about it, not because we ask.
Yeah, yeah.
But, yeah, they're serious. They're maybe anxious. There may be even a feeling, particularly if they've come individually, is that everyone wants me to be happy or not happy, but to have hope to fight this. And so sometimes it feels like they weren't allowed to talk about this. And this is a chance to bring up the concerns. Not everyone's that way. And so we may bring the issue up more gently when we're going in the domain and just how are you thinking about the future? And that's when we may hear about concerns. There's some people who will say, I don't really like to think about the future. I'm taking things one day at a time. But still in their conversation, they will and they may still say, "But I've made a will," or, um and some haven't, but, and it may be, though, that it's kind of implicit. We don't push people to talk about death and dying, but it typically does arise, but it may be the worries about pain in the future or worries about, how's my family gonna be if I'm not there, particularly if it's a young family, so there's it brings up the concerns without always talking about, like, death, so it may be more mortality in general, and people differ, and some people are quite comfortable with it. They have maybe seen family members who've died where it might be what we call a good death, where they were relatively pain-free and people were around. Yeah, so it depends too on their previous experience. and their age, perhaps. There's, many variables there, I would say, and culture and
That
beliefs, spirituality. And, that's important, like we were talking about, in some cultures more than others. And spirituality differs. Among our Indigenous people, it is often an issue that is talked about.
since we are approaching to the end of our interview, I will like to ask you one more questions with all you have present us today. We are living times when technology, yes, it's a part of our life,
Yes.
yes, and in the field of oncology, we can see it maybe um, more often and than other uh, domains. And for us as specialists, as psychoncologists, as oncologists, there is this statement that I would like to answer, if you agree or not, about the pressure to deliver quality results in minimal time.
No, that's very interesting. Well, I would say, like here, what our pressure might be is that we have longer and longer waiting lists. So once someone's been diagnosed with cancer, they may have the greatest distress. And we'd ideally like to see them quickly. But if they're waiting months, we need to have sessions that can be shorter. But when you talk about technology, so we can provide Zoom online, and we did that through COVID. But yeah, it's got to be evidence-based though, and that, that we can provide it humanely, but also efficiently, and I think ethically. And that way people can more readily be helped by us as well. Um, yeah.
Janet, thank you very much for being with us today. Thank you very much for all these interesting informations with this innovative therapeutic approach for patients with advanced cancer. Good luck on your research further, and hope to see you again to our interview series. Thank you
Thank
very much.
Don't forget to like, comment, share, and subscribe to Oncodaily on YouTube. Hit the bell icon to stay updated.